make sure you do participate today and apply for credit. If you have a heartburn, don't try that. Again, let me introduce myself shortly. I'm Nazim Nuddin. I'm director of the Fatty Liver Program at the Digestive and Liver Disease Division, Sinai Medical Center in Los Angeles, California. I would like to introduce to people that they don't need introduction. The first person is the very Okay, so let's start first our first learning objective, which is to summarize the epidemiology and outcome of NAFLD and NASH and the factors driving the progression to advanced fibrosis. And we have the person who did most of the work with us here today, who will tell us about that. But to start, I want to share with you an augmented reality NAFL include inflammation, and this is when you call it steatohepatitis or non-alcoholic steatohepatitis NASH. In NASH, inflammatory cells get activated and recruited to the liver and then secrete cytokines to produce inflammatory response within the liver. This activates the hepatic stellate cell, as you see here, causing it to become a myofibroblast that secretes collagen in the liver. This can lead to fibrosis and eventually progress to cirrhosis. So to make things practical, we're going to give you the most updated literature today, but it's great to put things in clinical
with central adiposity, a body mass index of 33 kilogram per meter square. Vague, right up a quadrant pain, and medications on metformin and some fish oil. So what next step with Victor in the style model? FIBROSpect or availability like ELF, transient elastography, for example, FibroScan, or shear wave elastography, MRI, MR elastography. Nothing is needed at this time, or I don't know. Thanks for that. And now I'll request Zubair to discuss why we think NAFLD is a problem, and what is the true prevalence of NAFLD and NASH in the United States and globally? Zubair.
Thanks, Rohit. So the most important issue about non-alcoholic fatty liver disease is that it's very, very common, and globally the prevalence of NAFLD is about 25%. So that means 1 out of every 4 will have non-alcoholic fatty liver disease. The highest prevalence is reported from Middle East and South America. The other key point, although NAFLD is very common, the type of fatty liver disease that's progressive, that we call non-alcoholic steatohepatitis, you heard that from Mazen just a minute ago, in general population is estimated. Of course, you cannot biopsy in general population, so you have to estimate that. That's about 1.5 to about 6.5% in the general population. So, and again, the highest prevalence is probably, again, in Middle East and South America. Another way to look at the burden of disease is to model it. To see where we're going in the next 15 years or so. This is a study both Rohit and I were involved with a few years ago, this is actually US data. And the bottom line of this study is that when you look at the patients that have NASH or advanced NASH, there is a doubling, almost a doubling of these patients over the next 15 years. In fact, when you look at the complication of liver disease, compensated cirrhosis, liver-related deaths, or total deaths, there is a substantial increase expected by 2030. Now, one group, we can go to the next slide. Here, the global prevalence. Patients we have advanced NASH. Mortality is increased in patients with type 2 diabetes and NASH. And of course, this is in the context of having more cirrhosis, HCC, and liver transplant. And please remember that of this disease is also substantial. When you look at the NAFLD with type 2 diabetes in the United States, it's expected that over the next 2 decades, the cost would be almost $2 trillion, $1.5 trillion, quite expensive disease. Now, when you're looking at this disease from different perspectives, it's important to remember that gastroenterologists view this disease as a very common disease, and they should look at presence of steatohepatitis and as well as steatosis, but steatohepatitis being the most important one. And those patients are primarily and predominantly in those that have type 2 diabetes and metabolic syndrome. Now, if you're a cardiologist or an endocrinologist, you're more concerned about cardiovascular disease, cardiac disease, and sometimes even end-stage renal disease and for the diabetics. But that's part of our goal, is to educate our colleagues in cardiology and endocrinology to remember that fatty liver disease is a hepatic manifestation of metabolic syndrome and type 2 diabetes, similar to retinopathy from diabetes or diabetic retinopathy being an eye complication. This is a liver complication. And for hepatologists, of course, when we see those patients who are at sort of more advanced stages with liver cancer, with end-stage liver disease, and predominantly those who come in for liver transplant candidacy. In fact, currently, NAFLD is the second indication for liver transplantation in the United States. And when you look at women or those who are older than 55, is the #1 indication in the United States for liver transplantation. So this gives you a great perspective about the burden of this important disease. So maybe Rohit, you can tell us a little bit about the natural history of this disease and how do we get to this end-stage consequences.
Thank you, Zubair. We think that we can broadly subdivide patients with non-alcoholic fatty liver disease into 2 subtypes. Number 1 is NAFL, non-alcoholic fatty liver. And it's really characterized with steatosis on the biopsy and a little bit of inflammation, but there's no ballooning and typically no fibrosis. Patients, about 80% of our patients who have NAFLD will have the non-progressive form of NAFLD called NAFL. Some patients, about 20%, may progress to NASH, non-alcoholic steatohepatitis, where we start seeing cellular injury, ballooning, and fibrosis. Now, patients can transition from NAFL to NASH, and that can take somewhere between 7 to 14 years. Once you develop NASH, one stage progression of fibrosis is about 7 years, 5 to 7 years per stage, assuming things are linear. Overall, if I see a patient with NASH, over the next 20 to 30 years, they could actually progress to cirrhosis. And this process is slow, but in about 20% of patients, it could be rapid, and they're classified as rapid progressors. Once you develop cirrhosis, then the risk of hepatocellular carcinoma increases to about 2 to 3% per year. And that's why we start screening patients, those who have NAFLD cirrhosis. Now, patients with NASH can also develop hepatocellular carcinoma without developing cirrhosis. But we don't know what the true incidence is in that population. Therefore, there are no recommendations because we have so many patients with NAFLD, and we really can't justify a cost-effective way of looking for hepatocellular carcinoma. But majority of the patients, if they were to develop HCC, it's really in the setting of NASH, metabolic syndrome, diabetes, and typically in those who have significant fibrosis, that is stage 3 and stage 4. So prioritizing those patients with advanced fibrosis and cirrhosis and making sure they get HCC screening and surveillance is important. Now, here is another way of looking at the same information, that what is the critical need? We think about 80% or 80 million Americans may have just NAFL, 20 million may actually have NASH, and among them, about 25%, or all these 5 million individuals we really worry about who have stage 3. This is where we start looking for hepatocellular carcinoma, as well as hepatic decompensation, and also risk for liver-related mortality exponentially increases. Next slide. This is an editorial I wrote with Leon Adams, where we looked at data from 2 trials that were published in Hepatology. What we saw from these trials is that they had patients with bridging fibrosis, and they followed them. The treatment did not work, but it was aggression if you had stage 3 fibrosis. So that you can use this slide when you see your patient. How? Well, patient comes to you, you've diagnosed them with stage 3 fibrosis. Patient will ask, doctor, what is my risk of progression to cirrhosis? So you can say, your risk is about 20% over 2 years. And so I need to monitor you appropriately for that. Who would be at high risk for progression? That would be the next question you'll ask yourself, or a fellow will ask you. Well, these are those with an enhanced liver fibrosis panel 9.8 or higher, lower platelet count, higher FIB4. Okay, that's good. Now, once you have cirrhosis, patient comes to you, NAFLD cirrhosis, they're fine today. Then they ask you, what is my long-term prognosis? Say, well, again, it's about 19 to 20%. So 20%, rule of 20% progression over 2 years for hepatic decompensation. So that's why I'm monitoring you for HCC screening, surveillance, and monitoring you for developing of ascites, variceal screening, and all those things then become important. What are key predictors? Again, liver function tests such as MELD score, Child-Pugh score, albumin are important. Portal hypertension could be measured by HVPG, presence of esophageal varices, and again, ELF of 11.3 or higher, and FIB4, a higher FIB4 would be associated with greater risk for hepatic decompensation in a cirrhotic. So these data could be useful as we discuss with our patients.
Rohit, may I ask you, this is really interesting. You're talking about advanced fibrosis and cirrhosis and in the setting of NAFLD. Are there concrete data that talked about the role of fibrosis and liver-related mortalities and all that? Can you share with us if there's concrete data about that?
Thanks, Mazen. Yes, this is a paper that we worked on with a large international consortium. Zubair was part of it, where we looked at stage-specific risk of mortality. So at stage 0, you can see to the left, I'm showing you liver-related mortality. It exponentially increases as you develop stage 2 fibrosis and beyond. And this is important because this is the reason why for registrational trial, we are NASH with stage 2 fibrosis or higher, because this is where we start seeing risk of liver-related mortality that increases. There's also data in the paper with risk of all-cause mortality also increasing with stage of fibrosis.
So this is very important point that Rohit made. Keep an eye and keep it in your head that fibrosis matters, and especially when starting with with stage 2 and higher, when it goes to the advanced fibrosis. So for us, we asked this question, and I think Rohit, Zubair, and I, and many people in the NAFL field, we wonder when screening is going to be adopted. And why this is important, because Zubair showed you the disease is so prevalent, such a big problem. It's almost a pandemic, but it's a silent disease. People don't know they have it. Sometimes they get vague abdominal pain and all this, and still the disease not diagnosed. It's also diseases and a lot of heart problems. And in addition, it's very prevalent in diabetes and in obese patients, which, as you know, they are on the rise. So the most recent AASLD guidelines opted not to screen for non-alcoholic fatty liver disease in patients with high risk. And the reason why, we did not have good cost-effective analysis. On the other hand, EASL, the European Society, opted to screen for NAFLD in high-risk patients, although there's no good cost-effective data. So that was a question that I was passionate about. I was hoping to, we can change the guidelines. So we did a study and we put this, what's called the Markov model. And let me give the entire credit to Zubair. Zubair, I forgot to thank you actually. You did a lot in the literature for this, and we were reading your papers up and down, and beautiful epidemiological studies. It showed the cost, showed the prevalence, and even he built Markov models starting at age 55, showing disease transition. So we used a lot of this information to see if is screening cost effective. What changed from the AASLD guidelines? So two things changed. Since then, we started understanding the value of this F2 and higher patients. Also, the old guidelines relied on cost-effective, or the recent guidelines relied on cost-effective analysis that did not look at these patients, the F2 and higher, rather they looked at the entire spectrum. Also, they used liver biopsy to screen the patients, which, as you know, is not practical and expensive. So we built this model thinking that let's look at non-invasive testing, taking in consideration their specificity, and let's screen those at risk and take the F2 and higher to treat them. So what we found is, next slide. Using the following. Ultrasound. We chose a treatment of intensive life intervention, which there's one paper by Villar Gomez that showed this intensive program, patient lose weight, and if you lose 10%, your fibrosis goes away. What we found that screening was cost effective, not if you use the liver biopsy, rather if you use any of these tests on the top, ultrasound or with or without liver enzymes, you followed by FIBROScan or VCTE to detect F2 and higher, and then intensive lifestyle intervention. And that is probably one of few studies that gonna justify
are also, as Rohit showed, of correlation between NASH resolution and fibrosis improvement. Then there are also a second of outcome, again histologic outcome, which is NASH resolution without worsening of liver fibrosis. So the FDA has agreed that either one of those could be a surrogate for an initial approval for drug trials of NASH. However, it's important to remember that most of the clinical trials of phase 3, as I'll show you, really have outcomes sort of part of those trials, meaning that you have to show ultimately clinical benefit. Now, there are a number of biomarkers that are being actually developed. Most of them are focused on fibrosis, so that can you actually replace liver biopsy with a non-invasive test that then can perform the same way as a good surrogate of ultimately the hard outcome, mortality. This is what we are going to do. And finally, I have to submit to you that there are two other important issues. First of all, as Rohit showed, the most common cause of mortality in patients with non-alcoholic fatty liver disease is cardiovascular. So whatever your drug has, either has to improve cardiovascular profile or at least not worsen it. So that's important. And hepatotoxicity, of course, you're dealing with a liver disease, so you don't want to have any drug that will have hepatotoxicity. Finally, from a patient perspective, the most important outcome is what we call patient-reported outcome. That has two importance. One, as you treat the disease, you want to make sure that patient's experience will be improved. And two, that your side effect profile is not going to impact the disease in a way that they can't tolerate it. And the reason for that is that this is a disease that you have to treat like diabetes, not like hepatitis C. So you have to treat these patients for long term. In that context, having a drug regimen that is actually going to be tolerable in long run and have a positive impact on PROs would be important. So those are some of the issues that would be really important to consider. Now, I'm just going to say that given that sort of requirement from the FDA, there are currently no approved treatment, as you know. There are some drugs that we recommend, and that came from AASLD guidance review, guidance document. And again, at the moment, vitamin E for non-diabetics, pugilidazone for pre-diabetics and non-diabetics, none of them should have actually cirrhosis. That's been actually suggested by the AASLD guidance document. But there is some suggestion that both of these regimens could improve histology. Now, statins are safe and should be used to treat dyslipidemia in the context of NASH, but statins by themselves have not been shown so far to be indicated solely to treat NASH, steatohepatitis. Now, as you heard previously from Rohit and Mazen, that weight loss is going to be important. And in this context, what's important to remember is that more than 10% weight loss actually will improve all histology, including fibrosis, which is the important outcome. The problem, of course, is that very few patients actually will achieve this. So about 10% of patients in the study that Mazen actually referred to achieved a 10% weight loss. And then, of course, the second problem is that sustainability of the weight loss. So even if you achieve it, can you sustain it in the long run? So I think it's important to remember that that's going to be something that we all recommend, because the weight loss is going to improve the cardiometabolic risk for patients, not only potentially improving the liver outcome, but potentially the cardiovascular outcome. So, and our practice, and there are some data to support this, is that the Mediterranean diet and moderate exercise improves not only visceral fat, but also hepatic fat. So that combination is what I actually use in my practice. Now, bariatric surgery is very common nowadays, and it's indicated for patients who are very obese or diabetic, and there is, of course, indication for this. And in fact, if you actually improve weight, and especially if you actually resolve diabetes, those patients will have significant improvement of their histology from a NASH perspective. But specifically, currently, bariatric surgery is not indicated as a treatment for NASH alone. Now, a lot of these patients are obese, as you heard, and have type 2 diabetes, so you could probably make a good argument to have those patients. And I actually recommend some of my patients who have had very hard time losing weight otherwise to receive bariatric surgery if they can actually qualify for that from obesity and diabetes perspective. And final note is that sort of endobariatric, the new sort of bariatric endoscopy or procedures are being looked at, different types of balloon, different types of procedures, and actually there is data suggesting that follow the same sort of pattern as you have in bariatric surgery. However, I would submit to you that the data is early. We don't have long-term safety data for this perspective. So at this point, it's really not standard of care as far as I'm concerned, and at least in our practice.
Greatness. So Rohit and Zubair, we finished the first stage of this talk today with, and you showed us the importance of these resources and how important it is. Zubair, you set the stage for how we look at treatment response, and you give us what we have today in terms of guidelines and what we have in hands, but also there are new things and updates in terms of like diagnostics, and eventually we're going to also tell you about treatments updates. But let's move first to the art of diagnostic, and we have the best speakers here to tell you about them. So Rohit, can you tell me about liver biopsy? And we hear with this NITs, non-invasive testing. So can you tell us what's the state of art update on the non-invasive testing for NAFL?
Sure. Thank you, Mazen. Thanks, Zubair, for setting the stage for discussion of non-invasive assessment. Here, what we've done is we've just listed a variety of tests that are available either clinically or become available in future. So clinical lab tests that you have it today that you could utilize, or clinical prediction rules are here. Among them, I think you should probably just remember one. That's what I do. FIB4 would be the one to use here. In imaging, you have various modalities. Mazen just discussed about ultrasound. You know, we've got CT, MRI. We'll discuss a little bit data on MR elastography, also on transient elastography. Then among biomarkers, we have many of those. We will discuss some data on FIBROSpect and ELF, because those. So if we go to the previous test, this slide, what we can do is we can risk stratify our patients. So suppose you work in a health system and you are taking care of 30,000 patients within the health system in your primary care service. Who needs to be seen and who needs to be prioritized? You could use an algorithm like that and apply it. So you could exclude patients and classify them as low risk if the FIB4 is 1.3 or below, or typically if it is below 1, you would classify them as low risk. These patients then don't need, frequent follow-up. They could be reevaluated every 1 to 3 years. So repeat FIB4. Basically, FIB4 includes an ALT, AST, age, and platelet. Very simple test to do. Now, those that have a FIB4 greater than 2.67, they probably have a significant disease, especially if they are in middle age group. So they're 40 or 50, 60-year-old. This is a high FIB4. They need an assessment. Depending on your clinic setup, they can get an elastography first and then come to your clinic. But I think FIB4 greater than 2.67 should be seen by a hepatology provider. And those that are intermediate, that is FIB4 is between 1.3 and 2.67, you definitely need another test. And typically people are using elastography, but you could also use a serum or fibrosis marker as well. Here's one example, FIBROSpect 2. This is a study we did in collaboration with Duke University. Duke University cohort was the we actually 396 patients and looked at the diagnostic accuracy of FIBROSpect. Well, for detection of stage 3 and stage 4 fibrosis, what does it include? It includes alpha-2 macroglobulin, hyaluronic acid, and TIMP-1. These are two things are common between this and ELF, which is hyaluronic acid and TIMP-1. P3NP is in ELF, and alpha-2 macroglobulin is here in FIBROSpect 2. Pretty good accuracy, and it's better than FIB4. And then we validated that. I use it gives you greater accuracy than FIB4. Typically, that's the comparison we are using. The test that we are developing a new biomarker, whether it's FIB4, FIBROSpect 2, FibroScan, or MRE, they should be better than FIB4 because we already have those available as clinicians.
Great. So I got a question from the audience about this FIB4 for those who they don't know it. To clarify it, FIB4 and NAFL fibrosis score, it's available everywhere, and you can go to Google to find a calculator. It's simple. It contains ALT, AST, platelet, and age. NAFL fibrosis score. You add glucose parameter, and you just there are iPhone apps as well as online, and you will find your answer immediately, which set the stage for me to ask our audience about the next test, which to know in a patient with NAFL abridging fibrosis, what cut points predict high-risk progression to cirrhosis.
Just a hint, this is from the 20% rule that we talked about.
That's correct. These studies will show you in a second. So again, ELF, for those that don't know, it's enhanced liver fibrosis test. And there are studies that Rohit showed that predicted this. So please pick one. Rohit, Zubair, what do you guys think? Rohit, did they listen to the slide?
That's good. This is early Saturday morning. We got 45% people, hitting the right spot. The others are close. And so I think those that picked 11.3, it would be for hepatic decompensation if you were cirrhotic. So I think this is good, but just review the 20% rule and then ELF greater than 9.8 associated with stage 3 and stage 4 fibrosis.
So let me show you the data on that. And again, NAFL and FIB4 and NAFL fibrosis score, we call them the simple. You can Google them and use formulas as Rohit explained to you guys. But ELF is a specialized test. It's not in the United States yet. It's in Europe. It will be here in the near future. And it's a combination of serum biomarkers of fibrosis, hyaluronic acid, TIMP, and P3NP. And what it showed here, there are two studies now, the simtuzumab as well as the galactin study, and they were around the same cutoff. So if ELF at baseline, look at it at the left, was more than 9.76, this predicted progression to cirrhosis. On the right, the value goes higher. If the ELF was 11.3-ish, your patient likely to progress to decompensating disease. So the left is progression to cirrhosis, and on the right, the higher number is progression to the subsequent step, which is decompensation. Let's take a look at imaging biomarkers. So VCTE FibroScan is the most commonly used. It's a quick machine. Many people have it in their office right now. You put it on the right upper quadrant and you get 10 measurements. It has the ability to tell you the quantity of steatosis as well as the quantity of fibrosis, and the other techniques as well, like shear wave elastography and RV and all that. Also, one of the most important tests for stiffness is the MR elastography. All follow the same concept about the measuring stiffness that reflect fibrosis. But let me show you now a new score called the FAST score. So the FAST score, again, this has been used from the transient elastography, VCTE. A lot of people know it as the FibroScan. So we promised you to bring you the most updated literature. This is a paper that was published in Lancet Gastroenterology and Hepatology. So the authors asked the following questions. Okay, so I have a FIBROScan that tells me about the amount of fat and amount of stiffness. Can something replace biopsy to tell me if the patient has NASH and F2 and higher? Again, they want to focus on the NASH and F2. And this is what they did in this score. They combined the steatosis from one of the fibrosis from one of the probes, and AST, which is blood, your liver enzymes. And they were fairly accurate in predicting those with NASH and F2 and higher. What is the indication of that? Why we need that? Because those are the people that they need pharmacological therapy. And the area under the curve was around 0.8 in the derivative cohort, close-ended validation cohort. One caveat about the FAST score that so sometimes the test will tell you the patient has high probability to have NASH and F2. This is good. But sometimes they tell you, well, the probability is low. But if you look at it, some people might have normal AST and high stiffness. So you need to keep eye on the stiffness for these patients. Again, the FAST, look for those for NASH and F2 and higher. Actually, you can find it on their app, and you can use it to determine those with NASH F2 and higher to go on pharmacological therapy. Right, along the same concept, now we're focusing on who needs treatment or not. And we're seeing things that have been presented recently to look for these F2 patients.
Yeah, I think, Mazen, you really nicely articulated the need in this area. If you looked at the previous slide that Mazen showed, the positive predictive value, as a clinician, what am I looking for? When I do a test, say this patient is positive for hepatitis C, how confident I am that it is positive, right? So you want to be like, okay, you got it, you got it. But here, if you look at the positive predictive value of this FAST score of 0.67 or higher, it ranges from 33%. So I'm only right 1/3 of the time what I labeled to 83%. So it's a big range. And that was the problem that I wanted to solve. So what we did was, if we go to the next slide here, is we asked the question, MR elastography and another test that is currently available. And so we first showed that MRE is better than FIB4. As I told you, that's my principle. Before I take any test at value, it has to be better than what's already available to a clinician like us. Then we validated this in Japan cohort, independent validation cohort, independently done biopsies, and independent MR elastographies done. So very good validation cohort because it's ethnically and geographically diverse from San Diego. This is the data. So this paper will be coming out in Gut from UCSD. And what we did was we then looked at odds ratio for predicting who has NASH stage 2 fibrosis or higher. Of course, MRE comes number 1, then FIB4, then we could pick AST or MRI PDFF, make it more expensive, but I wanted to make it something that you could use today if you had MR elastography available. So we took the top two, which is MRE and FIB4, and then we asked for a cut point. As a clinician, I want an answer to be absolute and I don't need an equation. This is my principle. So I said, okay, why don't we pick the optimal cut point on MRE? And it came to be 3.3 kilopascal. Then I asked, what is the optimal cut point for FIB4? And it came to be 1.6. And I say, if a patient met both of these criteria, you did an MRE that was 3.3 or higher, and you did a FIB4 that was 1.6 or higher, you have a positive predictive value of 97%. You can't do better than this. So then I said, okay, this is San Diego. What happens if we apply this test somewhere else, completely different? Test independently, more than 90%. So now you could apply a test, which would be now the gold standard if you were to pick somebody without needing a liver biopsy for treatment, if a drug were to be approved for treatment of NASH stage 2 fibrosis or higher. And that's the idea. Now we'll develop, ultrasound-based tests to replace this, but now at least we have a gold standard set. So we can conclude that FIB4 is better than the NAFLD fibrosis score utility, and this is sort of my conclusions for you in terms of summary. FibroScan is better than FIB4, that's why we're using, but MRE is better than FibroScan. And in terms of efficiency of combining biomarkers, I gave you an example where we could combine either FIB4 with FibroScan. We could use FAST, or we could use MR elastography plus FIB4, or we could also combine ELF with FIB4.
Let me move to the case quickly. For the sake of time, I just want to take a quick look, remind you guys about Victor, long-standing history of diabetes. This is the enzymes. And then, so again, we asked this question before. What would Victor is with risk of long-standing diabetes, you saw his lab. What would be your next step on this, on Victor? Liver biopsy, FIB4, serum biomarker test, transient elastography, MRI, MRE, nothing is needed at this time. I don't know now that we told you about non-invasive biomarker. And I'm going to answer one of the audience question. None of the imaging tests uses contrast. So neither the transient elastography or MR elastography. So you want to do the answers? Some changes here. I guess with question number 2, a lot of people pick FIB4. Rohit and Zubair, quickly, what do you guys think about this progress?
I think it's clear that the right answer is the FIB4 simplest test that you can get from the internet. You don't have to actually order any expensive test as the first line. But as Rohit just said, you probably will need a second line to even confirm more, to risk stratify your patients. Again, remember, all of this is to identify patients that have significant fibrosis, potentially stage 2 or higher. So here, of course, the question that was answer number 2 is the appropriate one, and there's an increase in the audience's response for this. But then, of course, you have to go to the next one. I certainly don't agree with that, with the audience that liver biopsy is really not indicated, at least in 2020 anymore as the next test. And I'd be interested to see what Rohit would say in terms of, yeah, FIB4, but then what else?
I think FIB4 in this case is just a stalling exercise. This patient is already in your clinic in front of you. He needs a biopsy. His AST is 65 and ALT is 60. AST is higher than ALT. So this is where I think you got to think. And so the FIB4 and all those stalling exercises are good, I think, before the patient gets in to see you. He's got 15 years of diabetes. He's got significant risk for advanced fibrosis. So in my clinic, he shows up, of course, FIB4 is built into my clinic note, but the order that I'm going to place for him will be a liver biopsy. He's got a pretty significant, AST that's higher than ALT, and he's not consuming excessive amount of alcohol. I'm worried that he's got stage 3 or stage 4 fibrosis, despite the platelet being normal.
So no, I completely agree. I think in our clinics where you have options for patients, clinical trials and other things, I think liver biopsy probably would make a lot of sense. But in most practices, especially if we're dealing with primary care or endocrinology, I think it's important to be to prepare the patient also. And I agree. I think if you wanted to bet on this patient, the likelihood of this patient just based on diabetes, and the fact that the patient has multiple risk factors for significant fibrosis, the patient will have advanced fibrosis. My goal is to just do some of these tests to not only actually confirm what I want to know, but also to prepare the patient for anything else I have to do, like a liver biopsy in the future. I think, the reality is that liver biopsy in the next few years will be, in majority of cases, will be replaced. Maybe, Mazen, you can say, when do you do a biopsy in any patient with NASH these days outside clinical trial?
Perfect. As I was actually just gonna go there to add a slight spin. And as you guys see, like we're focusing on this because you know how you want to manage treatment. So Rohit recommends a biopsy. It's great. It'll give us an answer. But you have this patient is, I feel nothing, man. It's like, you're gonna stab me with a biopsy. He's not gonna tell you that, but he goes home and he's not gonna show up again. So I look at their eyes and see, like, are they really gonna do the biopsy or not? But then you have, from what Rohit told you and Zubair told you, you have a menu of option that you can do non-invasive testing if the patient really doesn't want to biopsy, if he's not ready for clinical trials, that which the guidelines endorse, that you can do FIB4, and maybe what Zubair was saying, like to increase accuracy, you can couple it with another test, ELF, transit elastography, MREs that have been worked. But yes, this is a menu of options. And I want to move on to the next slide because we still have a lot to cover. But CME outfitter, just quickly go back for a sec. The answer, like the answers you guys have is great. You see now 21% they didn't know, it decreased, and nothing needed at this time decreased. You all recognize that this patient has diabetes, he's at risk, he has fibrosis, and all of you use something. So this is great. This is what we need today. Let's move on to the exciting part and what's cooking, what's in the horizon in terms of medications. But let's start with a video that will tell you, summarize some of the imperative mechanisms. So let's look first at the farnesenoid X receptor, or FXR. This is a nuclear receptor that is activated by its ligand, bile acid. You see here when the green bile acid binds, then the purple co-repressor is removed, allowing the yellow co-activator to bind. FXR regulates expression of genes involved in the bile acid metabolism, lipid metabolism, and glucose metabolism. Next, let's look at PPARs. These are nuclear receptors that regulate lipid metabolism. There are 3 isotypes: alpha, delta, and gamma. In each hepatocyte, PPAR alpha and delta regulate the expression of genes involved in mitochondrial metabolism of fatty acids. So if you have effective PPAR alpha and delta, fatty acids to prevent abnormal fat accumulation in the liver. However, if PPAR alpha and delta are defective, then these free fatty acids are not properly processed. Instead, the fatty acids accumulate in the liver, contributing to fatty liver and to the inflammatory cascade that we see in NASH, which can progress to liver fibrosis and cirrhosis. I want to show you another target. If we look again at the process of fat accumulation in the liver leading to inflammation, C2 receptors, CCR2 and CCR5. What they do is recruit and activate other cells. Here is a Kupffer cell that is started maturing, as you can see. The Kupffer cell then secretes cytokine, which will recruit monocytes into the liver to promote more inflammation. The Kupffer cell also activates the hepatic stellate cells, as shown here. Then, and as we saw earlier, the stellate cell turned into a myofibroblast that secretes collagen in the liver, which over time can lead to fibrosis and eventually cirrhosis. So there, we're going to talk about therapies now. Let's dive in. Please lead us.
Yeah. No, thank you again, Mazen. Let's just look at some of the target that Mazen was just talking about. So can we go to the next slide, please? Somehow I don't have the next slide, but anyway, there are a number of different targets that Mazen was showing that have to do with not only insulin resistant and lipid metabolism, lipotoxicity and oxidative stress. There are targets that would go after inflammation or immune activation, and then of course apoptosis, and finally fibrogenesis. And this is really not a complete list of all the drugs that have been actually tried in non-alcoholic steatohepatitis. I'm not going to get into all of these, but let's go to the next slide, so at least we can focus on some of the phase 3 trials. But before doing this, let me actually see how much the audience have been following some of the clinical trial data. So here is a question, and you can vote. Which drug trial met the primary endpoint of fibrosis improvement at week 72? Aurora, Resolve It, Regenerate, or Stellar 4? Let's go ahead and actually vote. We'll take a look at it and come back to the answers. All right, so now let's actually, so Regenerate is the one that 71% of the audience actually picked. That is actually accurate. So let's actually now look at the some of the data from phase 3. So this is a summary of all phase 3 clinical trials. The selonsertib, elafibranor, unfortunately, did not meet their primary endpoint, and Stellar 3 and 4 for selonsertib, and Resolve It for elafibranor. In these two drugs have been for now have been discontinued. Those that are in red, cinakinumab, resmetirom, and aramcol, they are still ongoing. Obeticholic acid is really the only one that has met the endpoint, and we're going to review that next. So let's look at the Regenerate phase 3 clinical trial. Remember that the first phase 2 clinical trial for obeticholic acid, which is an FXR agonist, was published from the NIDD, and most of the endpoints, histologic endpoints, were met. Regenerate is actually a phase 3 long-term study, so it's actually an outcome study, but the design of the study was to allow a month 18 interim analysis. And with the FDA's agreement with the sponsor, the agreement was that if the drug shows improvement of fibrosis by one stage without worsening of steatohepatitis, or NASH resolution without worsening of fibrosis, then the study is considered to be successful. So let's now actually look at the actual data. So the intention to treat analysis in terms of fibrosis improvement, as you can see, OCA 25 milligrams certainly is highly significant in terms of statistical significance, met the primary endpoint of fibrosis improvement by one stage without worsening of steatohepatitis. On the other hand, when you look at the NASH resolution, none of the arms of the study actually were better than placebo, except that you have to realize and remember that steatohepatitis resolution is very difficult to meet, meaning that ballooning is sort of becoming zero. There's improvement of fibrosis, of inflammation, and some of the other parameters that you have in the histology, that when you look at the individual features, histologic features of steatohepatitis, then actually you will see that there is actually improvement by the 25 milligram arm. More importantly, to the right, the graph to the right shows when you look at how many patients actually improve fibrosis versus worsen fibrosis, you'll see that in the placebo, as you have heard, is that there is a placebo effect. So 20% or so of patients both improved as well as worsened. But if you look at OCA 25 milligram, only 13% of patients over time actually worsened versus 38% that improved. Now let's look at more expanded protocol. The Regenerate study had allowed, it was primarily a stage 2 or 3 patients with biopsy-proven NASH. However, it did allow some stage 1 patients who had additional risks, for example, type 2 diabetes. When you actually analyze this expanded ITT population, now not only you actually have this improvement of fibrosis by one stage without worsening of steatohepatitis, now for the first time you meet the NASH resolution without worsening of fibrosis for 25 milligram arm. So this is actually quite encouraging. Now let's look at some of the other data that's been presented to everyone just in August of this year at the International Liver Congress. Fibrometer with either alone or with transient elastography or FAST score, as you heard about this. All of these non-invasive tests when you look at over 25 milligram, you see that is a significant improvement. In fact, that actually you'll see that at least for the first two tests, there is improvement even in 10 milligram. But the most impressive one, again, happened in the 25 milligram arm. The other analysis that was also presented is what is the sustainability of this improvement. And that's actually depicted in the next slide. And here you see that what happens to the non-invasive test at month 24. Transient elastography, FIB4, and ALT are depicted here. I just want you to just focus on BCTE or transient elastography. You see that from month 18 to 24, the improvement not only was sustained, but actually continued in the 25 milligram arm. So that's again very promising that the histologic improvement probably will also be reflected as you have this in this non-invasive test. So now let's look at some of the safety profile. First of all, to remember that most of the side effects are in general mild, and they were really similar across the three arms of the study. Now I'm going to mention two important sort of side effects. One, of course, is pruritus, and pruritus was higher in patients with 25 milligram arm, but it was pretty well tolerated. There was a study that actually was also presented at the International Liver Congress that looked at quality of life of these patients. And easily manageable. The second, of course, is the dyslipidemia that you see. There's an increase in LDL cholesterol in the 25 milligram arm, however, and also 10 milligram arm, however, easily managed with statin therapy. In fact, patients not only got back to their baseline and sometimes actually improved. Most importantly, look at serious adverse event. No difference between the three arms that it's actually of any consequences, including any plenty of data that suggests that overall there is actually good safety data here. So of course, per protocol, 18-month interim analysis that was pre-specified, and there was pre-specified endpoint that was agreed upon between the sponsor and FDA, that at least fibrosis improvement without worsening of steatohepatitis, that endpoint was met. Now, again, I want to bring you back to the idea that this is actually an outcome study. So the study will be ongoing, even if the drug is approved in 2021 for at least a 5 years outcome to make sure that it's clinical benefit in terms of decompensation, etc. And as I mentioned, there is also now data that with the ursodeoxycholic acid, at least as you improve in fibrosis, you also improve PROs. So in this context, of course, the drug has gone through some initial review by the FDA, but FDA has requested additional data, and I expect that the data will be provided, and that at some point we will have hopefully access to this drug that has shown efficacy and phase 3 clinical trial. So another drug that was very promising initially was selonsertib, which was an ASK1 inhibitor. And in phase 2, there was actually both invasive and histology as well as non-invasive tests that suggested improvement. Unfortunately, STELLAR-3, which was for bridging with patients with NASH with bridging fibrosis, did not show any significant improvement of the fibrosis, which is the primary endpoint. And STELLAR-4 was for cirrhotic, so selonsertib unfortunately was discontinued because there was no efficacy vis-a-vis placebo for both different doses of this drug. And finally, another drug that actually had gone through phase 3 was elafibranor. In the initial phase 2 clinical trial, GOLDEN, there was suggestion that steatohepatitis would improve, but unfortunately, phase 3 clinical trial that enrolled over 1,000 patients with stage 2 and 3 NASH. There was no improvement of, the study did not meet the primary endpoint. There was no significant improvement versus placebo, both in terms of NASH resolution without worsening of fibrosis or fibrosis improvement. And finally, the only other drug that I will mention is the sinequirvarok. And again, in the first study that was published, the Centaur study, which is a phase 2 clinical trial, there was some suggestion of improvement of fibrosis. So this drug is actually currently finalizing in the NASH Aurora study, which is a a phase 3 clinical trial, and the primary endpoint is, again, improvement of fibrosis by 1 stage or more without worsening of steatohepatitis. Large study, so we'll await results. So without further delay, let me actually ask Rohit to show you some of the other promising phase 2 clinical trial that actually can be also of great interest to you guys.
Thank you, Zubair. Now we move on to some of the drugs where we have some early results from the phase 2B program, and resmetirom is one of them. And this is a thyroid hormone beta receptor agonist. And the trial, the way it was designed, patient got treatment or placebo, and there were 60 milligram dose and 80 milligram dose, and they had a MRI PDFF, so looking at liver fat at baseline, and then week 12, and a biopsy at week 36. And what they found to the left is significant reduction in liver fat, significant reduction in MRI PDFF. And now we have data that if you start seeing significant reduction in MRI PDFF, and I call it as an MRI PDFF responder, which is 30% decline in PDFF, then it's associated with histologic response, as beautifully shown to the right. You can see NASH resolution rates higher than placebo, showing in yellow, and placebo in gray. No significant change in fibrosis in this 9-month, but there's a significant NASH resolution improvement. Now this drug is into phase 3 trial, looking at histologic response over 1 year. What about Aramcol? Aramcol is a fatty acid and a bile acid analog, and there was an initial study conducted in Israel where it was shown that it will reduce liver fat on MR spectroscopy, shown to the left. Based upon that, a phase 2B trial was designed. I was involved in that design, where patients were randomized to placebo, 400 milligram Aramcol, or 600 milligram Aramcol, and then a biopsy was done at the end of a year. What they noticed was a significant NASH resolution compared to placebo with the 600 milligram dose. Now, this is also in a phase 3 program. Semaglutide, the GLP-1, there's a lot of excitement about GLP-1. Why is that? Well, GLP-1 analogs are supposed to, and they're FDA approved for treatment of type 2 diabetes, but also cause weight loss. And we know that if you have significant weight loss, it can lead to improvement in NASH activity. So the trial was designed with 3 different doses of semaglutide, subcutaneous injection versus placebo, and large study, 320 patients with biopsy-proven NASH with stage 2 or 3 fibrosis in about 230, and they underwent a week 72 liver biopsy. And to the right, I'm showing you NASH resolution rate, significant improvement between the 0.4 milligram dose versus the placebo. So 59% met the primary endpoint here versus 17% placebo. And now these results would probably lead to a future larger, phase 3 trial that's under design. Next slide. Now we can move into some of the discussions on combination therapy. Some are already available, and we'll discuss some of them. I was involved in design and conduct of the Atlas trial, and many other investigators as well. In this, we combine an FXR agonist with an ACC inhibitor and an ASK1 inhibitor selonsertib, and looked at the combination of 2 drugs versus 3 drugs, and see if you can improve inflammation, fibrosis, and lipotoxicity. Then, of course, there are elafibranor and several FXR agonists. There's also a combination of CBC, which is a CCR2, CCR5 blocker, with an FXR agonist. There would be a numerous combination therapy trials that will be coming out in future. In the next slide, I'll discuss one of them. This is the Atlas trial, as I briefly alluded to, which I was involved in design. Cilofexor is an FXR agonist. So what we did was we used a lower dose of FXR. As Zubair pointed out, FXRs have 2 common side effects. One is pruritus, the other one is LDL increase. So What if you use the lower dose of FXR? You use the lower dose of cilofexor, 30 milligram instead of 100 milligram, and then combine it with Firsocostat, which is a ACC inhibitor. Selonsertib was also there, but that monotherapy arm was dropped once we got the phase 3 data on selonsertib. I want you to focus in the middle and look at the purple, which is the cilofexor plus Firsocostat treatment arm. It showed a 21% patient had one-stage improvement in fibrosis relative to placebo at 11%. No difference in NASH resolution. You can see progression to cirrhosis was higher in those that had bridging fibrosis in placebo compared to the combo group. The data that I'm not showing you is that there was a significant improvement, 2-point improvement in NAFLD activity score in the combo with Firsocostat and cilofexor relative to placebo. So that was significant. Other data were not significant because of the sample size, but we do believe that the combo approach is working with less side effect and improving liver histology. We also have data on machine learning that shows that there is improvement in fibrosis. So now this may move into either a phase 2B, a larger phase 2B, looking at the combo versus placebo, or a phase 2B/3 adapted design.
Back to Victor, 15 years of type 2 diabetes, dyslipidemia for 2 years, family history of metabolic syndrome. He's overweight, ALT and AST. You saw those. The AST-ALT ratio flipped, started looking at that numbers, suggesting that maybe FIB4 is higher. Platelet is a little bit on the lower side. So all of you got the answer correctly prior that this patient needs staging if you can have liver biopsy or a couple of tests. Let's go to the next slide, look at the intervention options. So lifestyle modification and improved type 2 diabetes. But I would strongly encourage if such a patient and all these parameters, that maybe you can consider him for clinical trials or what's available in the ASLD guidelines. Now, let's take this question. How do you monitor and manage Victor moving forward? Screen him for HCC, assess him for vaccination against hepatitis A and B, consider screening for esophageal varices, monitor him for disease progression, all of the above, and none of them.
I just wanted to clarify, as Mazen pointed out, Victor has a FIB4 that's 2.75, so it's above that 2.67 range. He's diabetic. Biopsy shows cirrhosis. So he's at risk for, hepatocellular carcinoma.
All of the above. It is all of the above.
Excellent.
So let's see the smart growth of today. That was fascinating, Zubair and Rohit. So what we need in our patient is to recognize the factors that lead to liver fibrosis, because that's what matters at the end of the day in terms of disease prognosis. And metabolic syndrome, diabetes are the highest risk factor. We showed you today that we can, if your patient doesn't want to do liver biopsy, you can integrate non-invasive testing, combine them, and have a meaningful results. Zubair started talked about the phase 3 trials and what's going to happen, and hopefully we're going to have a drug in the near future. But Rohit also showed you the state of art phase 2s and how we started looking at the disease as diabetes, combining medications to reach higher efficacy. And of course, we're not ignoring lifestyle intervention and weight loss and exercise, but like the failure rate, and you should tell your patient about this and add options, especially if they are F3s and F2s. Rohit showed you the progression to cirrhosis, which can happen in a short time. With that, I think we will take some questions. We have received good number of questions. One of the audience actually asked about the abnormal liver enzymes. And how about Rohit, if you take that question? Can you tell us about normal versus abnormal liver enzymes in this disease?
Sure. I think, so there was a paper in 2002 by Predictor et al., and based upon that, we assessed that for ALT, for men 30 or higher is considered abnormal. And so, many labs will go up to, 45 or 50 even. And so you could quantitatively a patient had an ALT of, say, 35 and it's been persistently elevated for a year or 2 years, that's, elevated ALT right there for you. And then the AST is also helpful. Typically what we are finding that AST has to be above 20 to start seeing some fibrosis. So not a absolute rule, but look at the AST. If you see AST above 20, so you want to think about the AST is below 20, then the likelihood is lower. Above 30, definitely pretty significant. So it's still normal AST based upon the labs. Our lab is 41 as upper limit of normal. Above 30, AST is definitely abnormal. So those two numbers to think about. Now, Predictor paper for women said ALT 19 or higher for women. Again, you gotta think about it at ALT of 20. I'm not jumping around to do a liver biopsy in a woman, but I think just to know what would be a normal upper limit. But typically, what I'm using is 30, and to trigger thinking about what I need to do next.
Zubair, I'm going to ask you two of the questions back to back. One of the audience was wondering about the role of metformin in these patients, and totally different angle. And I'm asking you this question because you recently put an effort on primary care to guide them. And his question or her question was how to diagnose and treat in primary care visit practice. So metformin first, and then advise the primary care what they should do and when they should refer.
Well, when you look at the clinical trial data, there's not a lot of great phase 3 clinical trial for metformin, but so far, whatever data that we have, it does not actually suggest that metformin can be used as a primary treatment for non-alcoholic steatohepatitis. There is no efficacy that has been proven. Now, of course, you can use metformin as a part of diabetes management, specifically in a group of patients. For example, PCOS patients would be on metformin. The prevalence of NASH is very high in PCOS patients because of common pathogenesis, of course. But using metformin as a primary treatment for NASH is really not indicated. Now, coming back to primary care and what do we do there? So the key here is that to understand that this is the most important liver disease. It's no longer hepatitis C. We have shown that not only the prevalence is high. When you look at the death rates in the United States, it's now being driven, and from a liver standpoint, it's being driven now by NASH. Hepatitis C is declining, and from a liver death, and NASH is increasing. So this is a real important disease. In the primary care setting, with very busy practices, I would recommend two things. One, look at your patient profile. If you have a patient that has multiple risk factors, metabolic syndrome, visceral obesity, type 2 diabetes, or a combination of these, the more component of metabolic syndrome you have, the higher the chance of having advanced fibrosis on the biopsy, or having a risk for mortality. That's the group that's really important to focus on. And then at least do something that's very simple and easy, which you all have access to, which is to do a FIB4, as Rohit suggested. And if that FIB4 is more than 1.3, as Rohit suggested, that's the patient that you can then link to the next step. And what do I mean by link? I mean that this is where you actually get that patient I personally use a transient elastography at the moment, but when we have ALF testing, I probably could use ALF testing, something that is relatively easy and potentially available in the community. And for us, if I see a FibroScan or a transient elastography that shows stiffness less than 6 kilopascal, then I say that patient is probably not going to be a significant, at least short-term or medium-term risk or liver-related event, and move them to the primary care. Those patients that have a transient elastography of more than 8 kilopascal, those are the ones that I submit to you that probably would be at some risk. But don't forget that the most important thing that you can do for these patients, at least when earlier stages, is to manage their cardiometabolic risk, which is with lifestyle modification, Mazen, that you suggested. So we still have to address that, and that can be addressed by our colleagues in primary care and endocrinology and others. But I think at least that's what I would recommend. Not a lot of tests, but just look at the profile of patient, do a FIB4, and then for those that are at quote unquote at some risk for significant potential liver-related outcomes to do the next non-invasive test before you get him to do it with his needle to do a biopsy.
Excellent questions. I'm getting so far, actually very detailed and smart. So let me answer this one quickly. We have a lot showing just the level of interest and how people understood the whole concept. So there is a question about, I think this is a brilliant question. Excellent program. Is there data on combining OCA and semaglutide? And I'll answer this quickly. This is a great question. Nothing on right now, but your question is because OCA showed efficacy in phase 3 and SEMA has a lot of favorable profiles, including weight loss and good cardiovascular outcomes. So that will be great if that study happens. Rohit showed the study GLP-1 SEMA with another FXR receptor that looked promising. I'm getting further question is, let me ask this again to the Zubair. I was asking about, there's a question, how long before OCA become available and how would you initiate the dose?
So of course, to read the FDA and when they're going to approve something is, I wish I was there. I would not be giving this. I would not be giving this talk. Actually, I would be doing it in something else.
This is like predicting the elections, right?
Right.
Well, which, by the way, now I think the results are out. But yeah, so go ahead.
So I expect actually that when all said and done, that we will have access to OCA, and I'm hoping in 2021 we'll have exactly when that's all up for grabs for right now. I think the FDA allowed the study to go on even after the first sort of review. It was just that they needed more data, and that's what we are that the sponsor is providing. So I'm hoping that in 2021 we'll have access. What dose I would recommend? First of all, remember that these studies have excluded patients with cirrhosis. Worry about OCA or any of the FXRs, it would be in patients who have advanced cirrhosis. So I wouldn't actually, just make sure you don't have someone with significant fibrosis that is turning into cirrhosis. But for others, it seems like the dose that's going to be effective is 25 milligram dose. But again, we'll just have to look at what is approved by the FDA. I suspect that will be the case. Where there will be an opportunity to, if you have, some potential side effect that you can see, can you dose reduce? Can you go for drug holiday? Those are some of the things that we have to learn. Those are not out right now, but the dose that is effective in terms of the clinical trials, 25 milligram arm for non-cirrhotics, of course.
Rohit, let me knock out two questions with you. We're approaching the hour. So two questions, one about the vitamin E. And the question in particular is asking if it's still recommended in non-diabetic NASH patients. And the other question, if you can give us a very short 15 seconds about, it's hard, genetics, biomarkers, and NAFLD and NASH.
Sure.
Audience.
Yeah, so both great questions. Vitamin E, yes, we use it. It should be used in a patient you did a biopsy, they showed NASH. On the biopsy, it's early, no fibrosis, or the patient has stage 1 fibrosis, doesn't really qualify for any of the other trials, and patient is non-cirrhotic. These are the 3 criteria that you want to use. Question number 2, you want to make sure that patient doesn't have family history or personal history of prostate cancer. Also make sure they don't have uncontrolled hypertension, because there's a small risk of increasing hemorrhagic stroke risk. decreases ischemic stroke risk. So that's for vitamin E. Genetic risk factors, very important. PNPLA3 is associated with higher risk for developing NASH, cirrhosis, and also hepatocellular carcinoma, especially in Hispanics. So currently we don't recommend checking for that, but in future we're developing therapies to target PNPLA3 protein, knock it down, and see if you can improve disease. TM6SF2 is also important, and now we're coming up with a genetic risk score that will have 4 genes that increase the risk, 1 gene that decreases the risk, and potentially see if we can use that clinically. Not ready yet.
Great. Any of you guys in pediatrics, which non-invasive test can be used? I got 2 questions about the pediatric population.
I think in pediatrics, one of the things to understand is natural history of disease. Majority of the patients don't have significant fibrosis. So I think you want to assess for fibrosis. The test that you could potentially use, again, FIB4 would be helpful. It's going to be lower because the age is lower in FIB4. So I think you want to do something. If the FIB4 is 1 or higher, then you want to consider, an approach that Zubair suggested in terms of using a FIBROScan in that setting. But I think focusing on cardiovascular risk, weight loss, metabolic improvements, those would be important, and they would actually prevent progression.
The only one thing that I would add to Rohit said, I completely agree, is that remember that there are other diseases that can masquerade as fatty liver disease, especially in children. Don't forget Wilson's disease, which is the great masquerader, and actually one of the ways that it actually can present is with fatty liver.
Indeed, indeed. Well, I'm sorry I cannot get to all questions today. Please feel free, to reach out. But with that, brilliant talks, Rohit and Zubair. Thank you again. This has been a great discussion, and thank you, our audience, for all the great questions you asked today. We hope we'll be able to use the information that we have shared to change the way you approach NASH in your clinical practice. We hope that you are updated, and you can refer to this CME website for the presentations today. So to receive the CME credit for today's program, complete what's in the screen and request. There's some clicks that you can use to request your CME credit. There's also instructions about the MIPS that being shown here. So please follow those, and don't forget. It's a little bit small for my coffee, but it looks great. With that, thank you very much, everyone. And I think we can turn to CNN or Fox News, whatever you watch, or go play golf, which I'm probably going to do now.
Thank you, Mazen. Thank you, Zubair, and thank you, CME marketers. Very nice program.
Thank you, guys. It was excellent. Thank you. Thanks, Mazen. Thanks, Rohit. Great to see you all.
Everyone.
Thank you. Bye.